Hi, everybody. My name is Fareeha Khan, and I'm an assistant professor here in the Department of Family Medicine at UF Health in Jacksonville. Today, my goal is to go over pain management in older adults, and we'll use the philosophy of start low, go slow. So about the Aging and Integrative Pain Assessment and Management Initiative, I think we have had multiple sessions through this initiative, which have been very helpful for medical providers and for patients themselves. And this is just some information about them. So some details about me, like I had mentioned earlier, I am an assistant professor here in the Department of Family Medicine, Department of Community Health and Family Medicine here at UF Health Jacksonville. I am family medicine trained, and I have also done an additional fellowship in geriatrics. And I was hoping to share my expertise in geriatrics when we're talking about how to help with pain management in older patients. Prior to coming over to Jacksonville, I worked in Charlotte, North Carolina as the geriatric trauma consultant, and I came across pain management for patients post-trauma. So I have some pearls that I was hoping to share with you today. So let's start off with the first slide here. So our objectives today are going to be to talk about different types of pain syndromes, and then how do we go about managing pain in older adults. And then we'll go over a criteria called Beer's criteria, which is very important in the world of geriatrics. We use that time and again to identify medications that are potentially inappropriate for older patients. And I'll go over that at the end of the presentation today. So pain assessment, we've all learned this, how to assess pain. And one thing I've realized is the numeric rating scale is one of the best ones, or the FACES pain scale, which you can present to patients to know more about their level of pain. It's very important to identify whether it's on the lower side, moderate, or high side, and manage it accordingly. Uncontrolled pain, as we know, affects mood and quality of life. So in older patients, our goal with pain management is to improve their quality of life and their functional status. So what are the three different types of pain syndromes? Primarily, there are two different types. One is nociceptive, which is due to activation of nociceptive receptors, which can be somatic, which is directly at the site of pain, and it could also be visceral. Example being appendicitis, which starts off around the umbilicus and then proceeds towards the right side where the appendix is. We have neuropathic pain, which is due to the irritation of the central or peripheral nerves. And then we can have mixed type of pain, which has both characteristics of nociceptive and neuropathic. Again, it's very important to identify what kind of pain a patient is having, because management will change accordingly. Now, when we talk about older patients, we also have to take into consideration cognitively impaired patients, which we will see whether it be patients who have any kind of dementia, whether they have had strokes, which limit their ability to explain about their pain. So the first thing to recognize is facial expressions, grimacing or frightened face, verbalizations, moaning, groaning, calling out can be signs that someone is in pain. Body movement, whether they're very rigid, tense, fidgeting would be important as well to figure out if they're in a lot of pain. Changes in interpersonal interactions, whether someone gets aggressive, combative, or socially withdrawn. Now, as you must have heard such cases, particularly in nursing facilities, where people have been found to be aggressive and combative. And in trying to address one of the concerns, instead of giving them antipsychotic medications, we have figured out that a lot of people are just in pain and they're acting out because of the pain. So it's important to identify if it's pain contributing to this behavior. You can also have patients who refuse food, have sleep disturbances, could be tearful, hallucinating, irritable, which can all be signs of pain. So it's extremely important to identify the behaviors and see if pain is contributing to these behaviors. What about pharmacological changes with aging? I think this is a very important slide, because management of pain for a younger patient is very different from an older patient. And this is exactly why, because there are changes that occur in the body as we age. Looking at the GI system, well, let's talk about absorption. There is slowing of gastrointestinal transit time, which means medications will stay in the body and slowly absorbed over time. Opioid-related bowel dysmobility is enhanced in patients. And that's why we see worsening constipation when older patients are placed on narcotic medications. Then how about distribution? So there is increased volume of distribution of fat-soluble drugs. So whenever we are prescribing fat-soluble drugs, we need to know that there would be an increased volume of distribution for these medications. Liver metabolism changes, so oxidation may decrease, resulting in prolonged drug half-life, which is extremely important because these drugs will stay in the system longer for older patients. Renal excretion changes, so GFR decreases with advancing age. Active metabolites may accumulate. One classic example is active metabolites of morphine, which tend to accumulate in people who have renal impairment, and then you can see adverse effects from that. And then anticholinergic side effects. This is one of the most important and concerning side effects in older patients, which encompasses confusion, constipation, incontinence, to name a few. And we'll go over this in more detail in just a bit here. So let's talk about pharmacological management. One of the best ways to look at this is to go through the WHO analgesic ladder. So it's a progressive ladder which starts off as at mild pain, where you may just use acetaminophen, aspirin, or NSAIDs to help with pain. Now, if the pain is moderate, then you can start adding a mild opioid, such as codeine or tramadol, and continue with your non-opioid management. And then if the pain becomes moderate to severe, then you're primarily adding a stronger opioid like morphine and fentanyl. And you can also continue with the non-opioid management. Now, at any of these stages, you can actually add an adjuvant, which we'll talk about in just a second of the list of those. But it's important to progress up this ladder based on where someone's intensity of pain at the time is. So let's talk about mild to moderate pain. So the most common medication that's used is acetaminophen. You can use a gram 3 times a day, scheduled. It is a relatively safe medicine in older patients. Beyond 3 grams is when we start getting concerned about effects to the liver. If someone has underlying liver disease or alcohol abuse, then you want to decrease it by 50%. So almost 1500 milligrams is where you would want to schedule the acetaminophen at. Now, lots of patients will tell you, doc, acetaminophen does not help me at all. I always tell them acetaminophen will help keep things at bay, and then you can use another medication as needed to help with the pain. So that's why I always go with acetaminophen as my first line. Then the next medication that I have used a lot while I was in the trauma service, when patients came in with rib fractures, musculoskeletal pain, lidocaine patch 5% has been very effective in helping with that kind of pain. You can actually place up to 3 patches. They stay on for 12 hours and off for 12 hours. And they can help significantly. Big side effects include rash and skin irritation that you can monitor for patients, not common. Sometimes we do have troubles with coverage for lidocaine patches. So what I recommend is lidocaine gel may be cheaper for patients, or there is 4% lidocaine patch, which is available over the counter, which patients can use if the 5% is not covered through their insurance. And then the third category of medicines are NSAIDs, non-steroidal anti-inflammatory drugs. Example being the most common ones, naproxen, ibuprofen, diclofenac sodium. All these 3 medications are pretty much used commonly. For older patients, recommended doses are listed here. This is where you should try to maximize patients at if you really need NSAIDs. NSAIDs come with their own side effects. Most common side effects include GI bleeding because of the decrease in prostaglandins, and also acute kidney injury. With acute kidney injury, the prostaglandins decreasing results in decreased renal plasma flow, resulting in the acute injury. So if someone does need non-steroidal anti-inflammatory drugs, I always recommend, number 1, have a baseline creatinine for them. Number 2, if you need to give it, use a short course and use it only as needed rather than scheduling it for them for months, because you never know when the AKI or acute kidney injury can occur for them. So that's basically management for mild to moderate pain. Now, what about moderate to severe pain? So the most common medications that are prescribed for moderate to severe pain in the narcotics category, starting off with hydrocodone, which is the mildest one, 2.5 to 5 milligrams. You can use it every 4 to 6 hours as needed. Then you can progress up the ladder with oxycodone, 2.5 to 5 milligrams every 4 to 6 hours as needed. And then lastly come hydromorphone and fentanyl patch. Again, it's really important to recognize that fentanyl patch is not recommended for opioid naive patients, so only for opioid tolerant patients. Again, this is not commonly prescribed. I have prescribed it once for a patient while I was working in the VA setting and who had multiple injuries while being in the war and was dependent on high doses of morphine. So we switched him over to a fentanyl patch. But again, not commonly prescribed for older patients. So that was about the opioids. Now, what about adjuvants? So the common adjuvants that we use are tricyclic antidepressants, such as nortriptyline, 10 milligrams QHS, or amitriptyline, 25 milligrams QHS. Now, I do not recommend tricyclic antidepressants for management of pain in older patients. Why is that? Because they come with anticholinergic side effects as listed here. In older patients, one of the most important side effects that we need to monitor are anticholinergic side effects, including dry mouth, constipation, urinary retention, and confusion being the big one. Everything with anticholinergic adverse, every medication with anticholinergic adverse effects has to be monitored very, very closely. So what about other antidepressants? If you're trying to avoid TCAs, well, we can use duloxetine or brand name Cymbalta. You can start low at 20 milligrams daily. Big side effect is dizziness, which we would need to monitor. But once you start 20, you can always progress up to 30 milligrams daily or 30 milligrams twice a day if needed. Then we have venlafaxine, brand name Effexor. You could start low at 37.5 milligrams daily and increase accordingly. Biggest side effects include increase in blood pressure and pulse. And then we have the common neuropathic agents that we prescribe, gabapentin and pregabalin. Now, gabapentin is very commonly prescribed by all of us. One of my suggestions for gabapentin is start the lowest dose. Again, coming back to the principle of start low, go slow. There's always room to go up if a patient tells you it's not helping me. So you could start off with 100 milligrams every night. Biggest side effects are sedation and lower extremity edema. If a patient tolerates it and they tell you it helps me, but not enough, then you can always go up to a higher dose of 300 milligrams at night or 300 milligrams every 8 hours as needed. And then the next medicine is pregabalin, 50 milligrams that you can use at night or go up to BID if needed, side effects being very similar. Again, looking at all these medications, it's very important to start at the lowest dose and progress up as needed. Now, coming into this important medication category called muscle relaxants. Again, very commonly prescribed by prescribers to help with pain. Now, when are muscle relaxants helpful? Well, when someone is having muscle spasms, they will be the most helpful at that time. Otherwise, you can use all the other medications that we discussed earlier. Why? To minimize muscle relaxants? Because they come with anticholinergic adverse effects. Most of them do. For example, one of the most common prescribed muscle relaxants is cyclobenzaprine. And my concern with cyclobenzaprine is that it has anticholinergic adverse effects because it's identical to amitriptyline. Another thing to note about cyclobenzaprine is that it has a longer half-life in older adults, which means steady state concentrations are 1.7 times more than that of younger patients. So the cyclobenzaprine or Flexeril will stay in the body much longer for older patients than younger patients, which means more side effects and higher risk for confusion and ultimately falls for patients. So if there's one medication that you can take home today to try to avoid prescribing for older patients, it is cyclobenzaprine. Now, sometimes you always think like, what else can I prescribe? If I can't prescribe cyclobenzaprine just because of its adverse effect profile, then you can think about other muscle relaxants. Now, baclofen definitely has its value in patients who have had spinal cord injury or spasticities related to multiple sclerosis. It is a centrally acting skeletal muscle relaxant similar to GABA. So definitely will have some sedating side effects. But again, it can be used for these specific conditions. Coming down to methocarbamol, this is again another medication that's very commonly prescribed. When I was working on the trauma service, every patient coming in after trauma would be prescribed methocarbamol, whether they be 60, 70, 80, 40s, or 30-year-old, everybody would get a gram every 6 hours. Now imagine if you give a 90-year-old 1 gram of methocarbamol every 6 hours, they will be completely somnolent. And that's exactly what happened with one of our patients. And that's when we had devised to update the pain management power plan for trauma patients and adjusted it to reflect 65 and over patients having a different set of medications to minimize risk of adverse effects of medications. So if you ever want to start methocarbamol, which is a centrally acting muscle relaxant, you can start at a low dose of 250 milligrams TID as needed. And then if you need to, you can progress up if a patient is tolerating it well. Again, I would like to share one case with you of a patient that I saw recently who had a left knee replaced, and post replacement she had severe pain, and her surgeon had prescribed her narcotics, and she was already on chronic narcotics, and then also methocarbamol. The daughter-in-law told me the patient was tolerating narcotics far better than she was tolerating methocarbamol, because the methocarbamol was completely zonk her out. So we tried to back away from the methocarbamol, and she became much more alert and verbalized much better after we had taken that down. So again, it's important to recognize side effects of these medications and prescribe accordingly. Now, like I was mentioning earlier, well then what can we prescribe if we need something for spasms? In my experience, I have noticed tizanidine has less sedating adverse effects. It is a centrally acting alpha-2 agonist is what we know so far. And it does not come up with, it does not have all the significant side effects from an anticholinergic adverse effect standpoint. Definitely has some. So you could start low at a dose of 2 milligrams at night, see how a patient is doing, and then you can go up to 4 milligrams every 8 hours as needed. But again, starting lowest would be the best thing for patients. So that was my brief on the muscle relaxants, which we do prescribe frequently. Last thing I want to touch base upon is the Beers criteria that I just discussed earlier in the presentation. So Beers criteria was designed by Dr. Beers, and it is a list of potentially inappropriate medications that we need to avoid, that we should avoid for older patients. We had this updated in 2019, and I will show you a couple of updated parts from this Beers criteria. So if you look at this slide, this actually goes over NSAIDs and the risks and the rationale and the recommendations for this. So if you notice, this is pretty much all the NSAIDs listed here, and it increases risk of GI bleed or peptic ulcer disease. They do recommend if you ever want to put someone on NSAIDs for a little bit longer, then you should add a proton pump inhibitor if needed. But again, that does not eliminate the risk entirely. And then this is pretty strong recommendation to avoid chronic use in older patients. And similarly, if you look at muscle relaxants, you will notice this on the left, this has the list of most of the muscle relaxants that we prescribe. And if you notice, it is poorly tolerated by older adults because of the anticholinergic adverse effects, as we had discussed earlier. And the recommendation is to avoid muscle relaxants as much as possible for our older patient population. So in summary, just going over our discussion, one thing that I will mention is always assess a patient's mood to determine if uncontrolled depression and anxiety is contributing to this increased level of pain if they start having that at all. Use non-pharmacological interventions as first line if possible, which includes physical activity, exercise, and referring to physical therapy. Virtual reality is something that I came across with one of the sessions through this organization. And I think there is definite potential for use of virtual reality in helping manage chronic pain for patients. And then lastly, you want to go ahead and do pharmacological management per the WHO ladder. I think it's really important for us to follow this ladder so that we can help manage acute or chronic pain for patients. So that was just my session for today. Thank you for joining in on this session. Again, if you guys have any questions at any time, feel free to send me an email, which is listed above under the presenter section, and I'd be happy to answer any questions later. Okay, thank you then. Bye-bye.